Hello guys, I hope you all are doing fine. Today I am going to explain a short topic which is frequently asked in an exam. Today I am going to talk about maxillary sinus, which is also called antrum of Highmore. It is air containing space that occupy the maxillary bone bilaterally. It is the largest part of the paranasal sinus. Maxillary sinuses are one of the first paranasal sinus to develop embryonically and begin in the third month of the fetal development. It is described as four-sided pyramid with base lying vertically on the medial surface and forming the lateral nasal wall. The apex extends laterally into the zygomatic process of the maxilla. The upper wall and the roof of the sinus is called floor of the orbit. The posterior wall extends the length of the maxillary and dips into maxillary tuberosity. Anteriorly and laterally, the sinus extends to the region of the first bicuspid or cuspid teeth. The floor of the sinus forms the base of the alveolar process. It is 34 mm from anterior posterior direction and 35 mm in height. It is 23 mm in width. Its volume is 15 to 20 ml. The sinus is lined by respiratory epithelium, pseudostratified and ciliated columnar epithelium. The maxillary sinus open into posteriorly, inferiorly and end of the semilunar hiatus, which lies in the middle meters of the nasal cavity. Its functions are humidification and warming of inspired air as well as prevention of the microorganism coming into entry. What is acute sinusitis? In acute sinusitis, a patient complains of dental pain and pain to percussion of several maxillary posterior teeth. From a radiographic view, we can do periapical, occlusal, Waters view and CT scan. Mucosal thickening caused by infection may obstruct the ostium of the sinus and allow accumulation of the mucus. What are the radiographic changes? It include mucosal thickness, sinus opacification, and nasal polyps. Air fluid level in sinuses. In acute sinusitis, it is managed with nasal saline, decongestant, antihistamines, and topical glucocorticoids. The goal of the sinus surgery is to remove abnormal tissue from within the sinus cavity and restore normal drainage through the ostium. This was accomplished with an open approach to sinus known as Cadwell-Look procedure. It is a surgical procedure used to enter maxillary sinus through anterior wall of the maxilla y canine fossa. What is the procedure of Cadwell-Look? First, LA or general anesthesia is given. Incision in the canine fossa region, then mucopurchal flap is raised, then a bony window is created in the anterior wall of the maxilla, then the maxillary sinus is entered and diseased tissue, cysts or foreign bodies are removed, then a drainage opening is created into nasal cavity and the flap is repositioned and sutured. What are the complications of Cadwell-Look procedure? The most commonly complication is oroenteral communication, which is abnormal opening between the oral cavity and maxillary sinus. Commonly occur after extraction of posterior teeth because their roots are close to the maxillary sinus. What are the causes of oroenteral communication? Extraction of molar or premolar, removal of RCT tooth, periapical infection, removal of cyst or tumor, improper use of elevator while doing extraction, trauma, cadaver look procedure. These are the causes of oroenteral communication. What are the signs and symptoms? Passage of air or fluid between mouth and nose, whistling sounds during breathing, bad taste or infection in sinus, positive Valsalva test. What is the management? It depends on the size. If it is smaller than 2 mm, usually it heals spontaneously. If it is medium size, usually 2 to 6 mm, we can do primary closure with suture. If it is greater than 6 mm, surgical closure using flap technique. What is the complication of oroenteral communication, oroenteral fistula and chronic maxillary sinusitis? What are the tests to diagnose oroenteral communication? There is bubbling of mucus or blood may be seen at the socket opening when patient exert pressure while closed nostril. If patient holds water in the mouth and they feel leakage of the oral cavity by nose, there is unilateral epistaxis and on affected site there is change in the resonance of voice. What is oroenteral fistula? It is persistent epithelialized tract between oral cavity and maxillary sinus. What are the causes? During extraction, during removal of cyst or tumor, if there is long-standing oroenteral communication, periapical infection and due to trauma. In long-standing oroenteral communication, or untreated oroenteral fistula, the antral lining will undergo thickening. That means it will undergo hyperplasia and there may be evidence of sinus polyp. What are the tests we can perform? Cotton wisp test or butterfly test. Hold a piece of cotton wisp with tweezer at the oroenteral fistula opening site and request the patient to blow through the nose with the nostril closed and the wisp vibrate under flow of air by oroenteral fistula. Second is mirror test. When we check the oroenteral fistula with the mirror, there is a fogging of mirror. The most widely used flap surgery for closure are buccal advancement flap, two-layered closure, palatal pedicle flap, and tongue flap. Buccal advancement flap. It is a technique used to close an opening between oral cavity and maxillary sinus. What is the procedure? First, we have to give an LA, then two vertical releasing incisions are made on the buccal side. A trapezoidal mucoperiosteal flap is raised. The flap is advanced medially over the defect. Then the flap is sutured to the palatal mucosa to close the opening. Then buccal fat pad grafting. It is a technique where buccal fat pad is mobilized and used to close the defects in the oral cavity, especially those communicating with maxillary sinus. What is the procedure? First, LA is given. Incision is made in the posterior maxillary vestibule. The buccal fat pad is gently exposed and mobilized. The fat pad is advanced over the defect and the suture to the surrounding mucosa to close the opening. Next is palatal flap, or it is called Ashley or pedicle flap. Posteriorly, based on greater palatine vessels, the flap is rotated and sutured on the oroenteral fistula site. The raw site is packed with dressing to allow secondary healing. Okay guys, I hope you will understand this, and this is very short topic. it come in 5 marker question, so you have to read it carefully and remember it. Thank you.